Hello, everyone, and thanks for joining Leveraging Data to Support Population Health Initiatives webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode. If you have any questions, please type them into the questions section on your GoToWebinar console. At the end of the presentation, we'll have a Q&A session as well. We'll get to as many questions as we can, but if for any reasons yours is not addressed, someone will be able to follow up with you after the presentation. We like to keep things interactive, so throughout the webinar, we will be launching poll questions for you to answer. Today, we have two presenters from IMO, Dr. Andrew Cantor, Chief Medical Officer, and Dr. Matt Cardwell, Project Evangelist. The content of the webinar today will focus on clinical data challenges, the challenges of interoperability, the role the pandemic has played in accelerating a solution, steps to solve the data problem, and gaining insight from patient cohorts. As mentioned before, if you have any questions or comments while our presenters are speaking, please type them into the questions on your GoToWebinar control panel. And with all of this being said, I would like to pass it over to Dr. Cantor.
Hello, everybody. My name is Dr. Andy Cantor, and I'm Chief Medical Officer for IMO. I'm an internist, and I'm a global health specialist, and I've been with IMO since it was founded in 1994. I also joined Columbia University in 2006 in the departments of biomedical informatics and epidemiology. I lead the Columbia International eHealth Lab, where I see how eHealth is impacting global health, particularly in low resource settings. I'm also a member of the board on global health at the National Academies of Science, Engineering, and Medicine. Let me begin with a little background about IMO. IMO has been the primary driver behind clinical interface terminology. Probably heard of us. We began in 1994 when few clinicians were even using electronic medical records. Today, we are the premier supplier of clinical interface terminology to the US and the English-speaking market, with more than 70% of acute care facilities, 4,500 hospitals, and over 500,000 daily clinician users in the US alone. Even as our customers and partners are struggling to manage the COVID-19 pandemic, IMO has been there, supplying terminology-related services to help with data capture, management, reporting, and also research. IMO has been a critical partner in helping clinicians capture their clinical intent within the health record for over 2 decades. We focused on delivering value by powering care as you intended, and we do this by building our platform in 3 ways: intelligently, intuitively, and intentionally. And we are now providing tools and solutions to help unlock value farther up the information chain. As I mentioned, IMO began our life really over 2 decades ago by helping clinicians easily capture their clinical intent. Once it became clear that clinical interface terminology could help clinicians effectively use health information systems, and that these systems could be employed to implement programs to reduce cost and increase reimbursement, these tools became a necessary component of just one initiative after another. Prior to the COVID-19 pandemic, the Office of the National Coordinator and the Centers for Medicare and Medicaid Services released new regulations that was based on the 21st Century Cures Act. And these were intended to continue this process that was started earlier to shift the healthcare system to a more value-based care system and to increase the role of patients in their own care. That was just a few months ago. The COVID-19 pandemic has forced the health system to dramatically increase its attention to the very issues that we identified previously: interoperability, data sharing, and population health-driven analytics. But now it is of increased importance, and it will likely dominate our attention over the next 1 to 3 years. So where were we just a few months ago? The 21st Century Cures Act version 1.0 actually was passed in December 2016 with some good intentions. I'm not going to go into the details of the act itself, but the Office of the National Coordinator, who was responsible for authoring those regulations called out by the Cures Act, released a federal rule just this March 2020. The proposed rule generated a lot of controversy over concerns about patient privacy, among other things. But the final rule, as enacted, required health systems and health information technology vendors to comply with new regulations over a 3 to 4 year time frame, with certain provisions that were actually supposed to begin in September of 2020. Now, the main purpose of this rule was, 1, to increase innovation and competition, 2, reduce burden and advance interoperability, and 3, promote patient access. I do want to note that although the COVID-19 pandemic has increased the need for these functions, the actual timeline has been extended by 6 months so that health systems can now focus on the crisis. 2 of the rules requirements will potentially have a dramatic change on the information landscape. The first is the regulations that increase the technical interoperability of health information technology. Now, this effort has been in the works for many years, but the focus on ensuring that technology can more easily pass information between systems in an understandable way is intended to accelerate adoption. These technical requirements include creation of a minimum data set that must be supported using the U.S. Core Data for Interoperability, or USCDI, and a standard way to transmit that data between systems using technologies like the Fast Healthcare Information Resource, you've probably heard of it, called FHIR, or the Consolidated Clinical Document Architecture, or CCDA. But the regulations not only address the technical reasons for why information is not flowing, they also focus on the providers. Decreasing information blocking prevents health systems from erecting barriers to data flow, like adding costs or contracts that block the sharing of information. Although our current fee-for-service payment model tends to de-incentivize information sharing, these new rules will inflict financial penalties on systems that fail to allow patient data to be shared. The combination of these 2 rules, the increased technical interoperability along with decreasing information blocking, will likely result in a tidal wave of data. Clinicians and data analysts, already burdened with trying to unlock data from massive amounts of data, and unlock value from massive amounts of data, are now going to have even more data to deal with. The healthcare industry is really at a critical junction now. We are already straining under the demands of big data and frequently poor quality data. The high hopes of artificial intelligence and health information technology have not had the impacts that we had hoped. And the providers and the very system itself was on the brink of breaking even before the current pandemic. Add to that the potential tidal wave of data unleashed by these new regulations, and we have a very real threat. It is essential that we learn to control the wave, transform its power from a destructive force into a force that can improve care and strengthen the system. The current pandemic has accelerated the need for data and interoperability. The crisis has stressed our ability to deliver care like never before. Careful management of resources, both human and material, is required if we are going to ensure that we can continue to deliver care. While at the early phases of the epidemic required lots of testing, diagnosis, and reporting, the current phase is focusing on how to best manage the treatment and track infections. Further research is required, whether about specific types of therapies or to better understand who is going to do poorly and require special attention. This requires highly granular patient data from many different data sources quickly. The crisis has already led to the release of a concept paper from the original bipartisan authors of the 21st Century Cures Act, Representatives DeGette and Upton. Dubbed the 21st Century Cures Act 2.0, this concept paper highlights that responding to COVID-19 and any future pandemic requires us to manage populations, processes, and resources with data. It contains a lot of resources to help improve testing and to help people get through the current crisis. And it also tries to improve the national infrastructure to be prepared for the next one. However, we still have the pre-existing challenge of how to transform data into actionable insights to drive population health initiatives and to care for individual patients. And we need ways to track our effectiveness with quality metrics and easy reporting to drive clinical care and population health initiatives. But how are we going to transform this data tidal wave? One way to get a handle on the data and make it truly usable is to understand the steps it must take on its journey from collection to use. Bringing together data from different sources with different formatting is a necessary first step. It will be essential that centralized databases of patient information that are created from multiple data sources are comprehensive and credible so that providers can trust the collected data. Once aggregated, the data will need to be represented, but will likely be represented in dissimilar ways within the resulting database due to the different formats in which it arrives. It will be necessary to normalize data to a common meaning, preferably at the highest level of specificity. And Dr. Cardwell is going to provide an example about this shortly. Data is typically captured at a particular level of granularity that may ultimately differ from the level of detail needed when it's used. Nimble transformation of data from one form to another, depending on a particular use case, is the third critical capability for health information system developers and implementers to consider. And finally, filtering through the vast volume of EHR's data and then prioritizing, organizing, and quickly presenting the information needed for the use case at hand will significantly reduce the cognitive overload that clinicians may face and highlight exactly the right information for the right patients at the right time. So let me recap what I covered before I pass the baton over to Dr. Cardwell. We were already struggling to make good use of our data before the current pandemic. New regulations increase the challenge by increasing our interoperability and decreasing information blocking. The COVID pandemic has accelerated both the need and the amount of data. And through effective aggregation, normalization, transformation, and summarization, the health IT industry can create solutions that appropriately manage the large amounts of data housed within our healthcare ecosystem. For clinicians, analysts, researchers, for all users. So let me pass it back over to Jory for our first poll question today.
Awesome, thanks, Andy. If everyone could refer to your screen, we're going to ask a poll question. Are you experiencing increased data challenges produced by the COVID-19 pandemic or new regulations fostering interoperability? Yes, primarily one, due to COVID-19. Yes, primarily due to increasing interoperability. Yes, due to both. No, or are uncertain. Give you a few more seconds. Awesome. I am going to close out. Now I'd like to pass it over to Matt Cardwell.
Matt, you may be on mute.
Thank you, Dr. Cantor, and thank you, Jordan. My name is Matt Cardwell. I've been with IMO for a little over 10 years now after a short stint as an academic mathematician. Over that decade, I've had the honor to lead our implementation, technical and clinical services, and product management functions. Now, as product evangelist for the organization, I have the immense pleasure to continue my work with our partners and customers and across the organization to build great products that solve big problems in healthcare. As you just heard from Dr. Cantor, one of these notable challenges we confront together is interoperability. He briefly described those 4 key aspects of the data journey that are key to unlocking interoperability at an organizational and individual clinical user level. The key focus for the second half of our presentation will cover the normalization and transformation aspects of the data journey, with a particular emphasis on opportunities to maintain granular data through the use of clinical interface terminology, which we'll define a bit more specifically in a couple of slides. Before we cite some specific examples, I want to make clear some of the use cases for normalization and transformation. As Dr. Cantor mentioned earlier, the data transformation is key because the level of specificity of information captured within a system, or to what that data is normalized, may differ from what is ultimately required to answer a specific strategic question. A first common use case is for population health management. We may want to identify cohorts of patients with similar conditions and take specific actions. A meaningful and timely use case, which we'll also discuss in a few minutes, is to identify COVID-19 comorbid risk cohorts. That is, those patients that are at higher risk for poorer outcomes in order to prioritize testing or vaccination at a point where that should become available. The second use case is for quality improvement initiatives, such as monitoring and driving improvements for diabetic patient populations. Third, clinical decision support provides clinicians guidance in a variety of contexts to adhere to evidence-based standards of care in order to improve patient outcomes. Necessarily, all 3 of these use cases are interrelated, but have a specific common thread requiring the accurate identification of patients with common conditions. In a minute, we'll talk about the power and importance to utilize an interface terminology to serve these use cases. But first, let's identify what we mean by that term. The visual on the left-hand side of the slide effectively illustrates what we mean by clinical interface terminology, which is a link from a clinical term, one that a clinician would use to describe a condition, with a variety of mappings to relevant metadata and administrative terminologies. In this case, the visual highlights a term taken from the IMO core terminology, formerly known as Problem IT, which provides a bridge that connects a clinician's own language to standards like ICD-10 or SNOMED CT to power a variety of billing and reporting use cases without requiring clinicians to limit how they tell a patient's story based upon constraints imposed by those vocabularies. For instance, the term in question, as you can see on the slide, requires multiple SNOMED or ICD-10 codes to fully represent that concept clinically. Very likely, as you heard the stats from Dr. Cantor, you're using IMO or another clinical interface terminology within your EHR. However, we have seen a variety of instances where a clinical application cannot properly send or receive information with that same level of fidelity. For instance, many interoperability transactions will only send a single SNOMED code, which in this case would not capture all of the clinical details supplied when initially documented. For this reason, it is important that clinical applications can send and receive this level of clinical detail that is highly leveraged within the EHR applications and is waiting to be mined for a variety of those use cases that we posed a moment ago. The slide highlights the difference in a single patient's calculated risk score, but this information loss will have impacts when extrapolated across a population or when applied to clinical decision support, as the understanding of clinical staging has been lost. We'll now talk about a specific example of normalization and transformation, leveraging a clinical interface terminology. Consider the information on the left-hand side of the screen. Some of it's coded, some of it is only codes, some of it is only free text, but none is in a common language. In this instance, IMO's clinical interface terminology has been leveraged to establish a common language for interpretation. Next, a value set which is based upon the same clinical interface terminology that was used for normalization is applied. In this case, the value set in question is the collection of all descriptions which refer to diffuse large B-cell lymphoma, excluding stage 4, which is used in that key transformation step. As Dr. Cantor mentioned earlier, the information is not at the appropriate level, and we need to cross-reference against that to find the data set of interest. In a case study that applied normalization and transformation techniques to a randomized set of 10,000 patients in the manner just described, we saw the technique that applied a common clinical interface terminology prior to that key transformation step as more effective in identifying patients than the unnormalized data set itself. This example highlights just one instance in roughly 60 clinical conditions where we saw similar performance. Generally, cohort identification can be done at the level of the codes received from a transaction itself, ICD-10 or SNOMED in this illustration, though doing so requires additional maintenance and may not be comparable, and furthermore, may not allow segmentation at the level of detail of interest. The imperative for transformation is that data in its current context isn't in the right form to answer the specific question of interest. For instance, identifying cancer patients by stage can't be built with ICD-10 CM codes because ICD-10 doesn't capture clinical staging, which we see in this example. However, even in a case where SNOMED codes are supplied, this example also illustrates the importance of retaining detail throughout all stages of the data journey. Another timely use case for data transformation is understanding COVID-19 comorbid risk. As the COVID-19 pandemic unfolds, it is clear that patient outcomes are affected by comorbid conditions. Chronic conditions, including but not limited to hypertension, heart failure, COPD, and diabetes, appear more likely to result in severe diseases from SARS-CoV-2 infection. However, as of May 2020, the relative risk imparted by various pre-existing problems is unknown. In fact, it can be difficult to make educated guesses. For example, as of just last month, there is some evidence that mild asthma may not impart substantial risk, contrary to what we might have assumed. Organizations such as the CDC or NIH have outlined conditions that may warrant extra attention for affected patients, such as stricter precautions, closer monitoring, more education, or prioritization for vaccination if that becomes available. Informatics teams at Epic, Cerner, Regenstrief, Health Catalyst, MITRE, and others have begun creating value sets to identify such patients. The ICD-10 and SNOMED codes used to define these cohorts vary significantly across these efforts. This variability illustrates some of the complexity of identifying what these categories are and how these categories translate to patient populations for some of the use cases we regarded earlier. The application of a clinical interface terminology can be effective to break up categories into more specific ones, such as what we see for chronic kidney disease. Oftentimes, subcategories may be difficult to achieve using just ICD-10 or SNOMED alone. In this portion of our discussion, we've talked about specific applications of clinical interface terminologies. We began by discussing the importance of systems sending, receiving, and understanding clinical data using a clinical interface terminology. Next, we discussed the power of a clinical interface terminology to leverage additional specificity or simplicity within a clinical interface terminology in order to transform data to be at the level of specificity required to answer a specific question. With that, I'll turn it back over to Jordan to ask poll question number 2.
Thanks, Matt. If you could all direct your attention to the screen. Are you confident in your organization's process of normalizing data? A, we've got it covered. B, somewhat confident. A, we could use help, or don't know. All right, just a few more seconds. Okay, I'm going to close out. Thank you. Now back to Matt.
Well, actually, it'll be me. Thanks, Dr. Cardwell, for that detailed analysis of the middle steps. And I thought maybe I would kind of conclude by just summarizing some of the key takeaways that we talked about today. The first is that this tidal wave is going to challenge providers and health systems to be able to handle and respond to the massive amounts of data and the need for that data in a very timely fashion. We know that responding to COVID-19 and other population health use cases is going to require highly granular data to help us understand the way to appropriately treat as well as manage our limited resources. We've described for you a data journey from granular data to clinical population insights, and the 4 key steps, although we focused on 2 of them today. That normalization step, which is really about coming to a common language, hopefully at a granular level across your enterprise, and then the ability to transfer that highly granular data into appropriate form to use for particular use cases. And finally, we hope that we could turn this devastating tsunami into a tremendously powerful resource to advance the practice of medicine and ultimately improving the quality of both clinicians' lives and those of their patients. So we thank you for listening to our presentation today, and we'll turn it over for questions and answers.
Awesome, thanks, Andy. All right, at this time, we'll be kicking off our live Q&A session. So if you have any questions from today's webinar or questions you had coming into the webinar, please enter them now, and our team will begin answering questions live. Just so you know, as we start receiving your questions, please excuse any brief silence for our team to review and answer.
Dr. Cantor, one question that often comes up is that there are a lot of issues inherent to leveraging clinical interface terminologies regarding interoperability questions. Can you speak to why we aren't just better off using the standards themselves? And maybe how do we think about more concretely addressing some of those challenges beyond ways that we've discussed already?
Sure. Well, there's no question that the intention of the standards are to provide a universal way of doing some of this transformation that we've talked about, and of the normalization. And it does have certain limitations, as if we've already talked about. There are certain use cases where the standards really are the way that you should be appropriately transforming and reporting, because that's what's required by the, let's say, the quality body that's maybe monitoring that. But I think what we've shown today is that even managing those standard value sets is challenging, not only because you don't exactly know where to go, but when you actually get there, there's often a multitude of different standards organizations or different opportunities to choose from a value sets, which might actually be difficult to distinguish without the appropriate level of documentation and so on. And so having a reliable source that is able to remove some of that unnecessary variability that we talked about earlier is an important step. And then I think, as we've described here, there are numerous use cases where the standards themselves, although theoretically conceivable, like SNOMED as a post-coordinated terminology, allows a lot of granularity. But the way that that data is actually captured within the health information system makes it very hard to query and to transform. And so that's where this use of interface terminology can be really helpful. And some of the slicing and dicing that Matt described earlier, whether it's for COVID or for oncology or any of the other patient populations, can really benefit from the use of the interface terminology.
Dr. Cantor, are there specific areas where organizations can focus their workflows to address some of these challenges?
I think it's all about providing value. And before COVID-19, it was really about the quality improvement metrics, and perhaps some of the key populations like oncology, where careful or fine tuning of patient cohorts really could drive much improved care through managing their care management. We also knew about large population burdens that we were in chronic disease that we were all struggling with, like diabetes, chronic lung disease, things like that, that also could benefit from just good cohort definition. But I think that with the COVID-19 pandemic, everything has sort of been turned on its head, and that the need for capturing clinical information at high level of granularity and then quickly turning that into appropriate either care management programs or being able to funnel that data to research organizations. And within the COVID-19 situation, there's a lot of universal, I shouldn't say universal, but certainly large scale consortium that are forming around shared data. And the ability to ensure that that data can be shared at the level of granularity necessary to actually discern some of these key insights, but also then to be able to transform that data into meaningful insights for researchers or for ultimately care management is going to require this type of transformation that we talked about today.
One other area of focus that I think is perhaps some low-hanging fruit is to speak with your EHR vendor to make sure that you're leveraging capabilities that IMO and these vendors have already provided as options within the systems. For instance, being able to send and receive this coded information, make that easily interpreted so that these systems are applying the clinical interface terminologies that many of you are licensing already. Dr. Cantor, anything further that you would want to comment around some additional benefits of data normalization?
Sure. I mean, I think, for me, and I've been following the COVID pandemic fairly closely because of my sort of global health as well as my IMO roles, that data was being sort of aggregated from many different places. You know, in a lot of cases, it was like even the parking lots out in front of the hospitals or clinics where these testings were being done. And the challenge of being able to take that information that was being captured in Excel or RedCap, sometimes other forms of mobile health type tools, and bring it into the enterprise and combine that with the data from the EHRs was a real challenge. And I think IMO certainly helped early on by providing terminology out for sort of open use and to ensure that data was being captured in the most granular way, in a way that translates to SNOMED and ICD and things like that are necessary for doing some of that integration. But having data across your enterprise, whether it's from your parking lot or perhaps from research databases, all coded the same way in your data warehouse or in whatever your data aggregation tool is really essential for you, I think, to be making the best decisions possible and for your organization to take care of patients in the best way. But when we then think about how that data then moves between enterprises and start looking at some of the consortium that are going on, like the COVID-19 Healthcare Consortium, which I think has something like now 800 partner organizations, the need to share data to solve this problem is really important, and to lower the barrier to doing that in an effective, granular way is just a key tool for helping solve this crisis.
I think one important facet of that is being able to have the same information speak many different languages. One question that I see coming up in the chat regards ICD-11, and it's more specifically asked around how it impacts the coding environment. But I think just broadly speaking across the clinical environment, in any case where where a large-scale change is required, be it the ICD-10 conversion that we confronted in 2015 here in the United States, or various reporting requirements, electronic clinical quality measures, or here domestically, or a variety of the concerns that our international partners see as well. Being able to have data that's conversant in many different languages all at once, without necessarily needing to recode that data all the time because it's attached to something that can move. The standards are constantly changing. We're seeing even a higher degree of variability here during the COVID-19 crisis. But as as we look down the road towards ICD-11, I think the general thought is that some of these standards will come closer together, but we're certainly not there yet, and having an efficient bridge is important, both in the problem diagnosis documentation side of things, as well as discussing procedures, labs, imaging studies, and surgical procedures, among others. Anything further that you might add on the ICD-11 question, Andy? Specifically,
I think you did a great job.
Around...
Yeah, I think of certainly in the United States, that's unlikely to probably be here for a while, in 7 to 10 years probably. But I do think that on an international front, there is a lot of hope that some of these new standards will more closely approximate each other, and so there'll be better collaboration between, let's say, SNOMED CT and ICD. And there's also more hope that the ICD-11, because it's a more dynamic compositional language, that there will be more electronic tools to make it easier for people to find the right code by essentially searching and building it. IMO has always had a very pragmatic approach to dealing with post-coordination and some of the challenges that coding requires, and that we think that there will always be a role for interface terminology to help bridge the gap to quickly get the users to the right semantic content to drive whatever use case that they want. And sometimes that use case feels is different than the one that the coding system was initially sort of devised for. And so I think that what we're really talking about here is figuring out how to find an interlingua that really does capture everything that the clinician wants, and therefore make sure that we're providing value to them, and that the downstream requirements to drive particular outcomes and extracting value from that data is as simple as possible. And mediators like interface terminology and appropriate value sets that are able to transform data from one level of granularity to another are going to be tools that will be essential regardless of what the outbound coding systems are.
Okay, it looks like questions are winding down. So we're going to go ahead and close out for today. We hope you found the information in today's webinar useful. And if you want any more information about IMO solutions, please contact your IMO client and executive or email sales@imo-online.com. Once again, thanks for attending and stay healthy out there. Goodbye.